So the last speaker today is Esther Salazar. So Dr. Salazar is a senior mathematical statistician in the CTP at the Food and Drug Administration, the FDA. Her research activities focus on health effects of tobacco product use, population modeling, survey data analysis, text mining, machine learning techniques for big data, and Bayesian analysis. At the FDA, Dr. Salazar has been actively collaborating with modeling and simulation activities that can be used to assess the health impact of tobacco policies and tobacco product market authorization in the U.S. So let's welcome our last speaker, Dr. Salazar.
Hey, good afternoon, everyone. My name is Esther Salazar from the Office of Science, Center for Tobacco Products, FDA. First, I would like to thank the symposium organizers for this invitation and for the opportunity to provide some details about the modeling approach being used by CTP to quantify the potential public health benefits of a nicotine product standard. As a disclaimer, this is not a formal dissemination of information by CTP, FDA, and does not represent agency position or policy. I will start with a brief overview of population modeling in the context of tobacco regulation. Then I will introduce the population modeling approach being used by CTP for a potential nicotine standard. I will describe the model assumptions, input parameters needed to run the simulations, as well as model outputs. Then I will briefly present an example of this model considering the implementation of the potential nicotine standard in the US. And I will finalize pointing out some limitations and future directions for population modeling. Population models, such as microsimulation and macro-level models, have been used in tobacco research for years. For tobacco regulatory science in particular, these models were applied to model the potential impact of regulatory policy at the population level, including users and non-users of tobacco products, and to evaluate the potential health impact associated with the introduction of a new tobacco product through pre-market product applications, substantial equivalence, as well as modified risk application pathways. Today, I will especially focus on the use of a modeling strategy to quantify the potential public health impact of enacting a regulation that makes cigarettes minimally addictive by setting a maximum level of nicotine in cigarettes, called the nicotine product standard. Since this modeling strategy, as well as other modeling approaches, rely on assumptions and construction of input model parameters, I will also point out some challenges researchers are facing to populate these models. As a brief introduction of this modeling approach, in 2015, the Center for Tobacco Products developed a dynamic population model called DPM model that was in collaboration with Sandia National Laboratories. This model was developed to evaluate the population health impact associated with the introduction of new tobacco products as for the evaluation of regulatory policies. A detailed description of the dynamic population model approach, including model evaluation and validation, with an analysis intended to examine the effects of the introduction of the hypothetical new tobacco product in the marketplace in the US, was published in the PLOS ONE journal in 2015. Later in 2018, CTP used the same model approach to quantify the potential health impact of enacting a nicotine standard rule. Results for this analysis were published in the New England Journal of Medicine in 2018, and I will briefly discuss results from that analysis in the next few slides. The DPN model, this is just a brief summary of that model, could be seen as a multi-stage model that considers tobacco use behaviors such as product initiation, cessation, switching, and dual use from one or more tobacco products and assess the effects of that data projected product use prevalence, mortality, and morbidity outputs attributable to tobacco use. The model is initialized with a starting population stratified by age, sex, and tobacco use status, taking into consideration the number of tobacco products predefined in the simulation setting. Each subpopulation is then updated over time, considering demographic changes related to birth, net international migration, and death. Then individuals from each population have a pre-specified probability of dying according with their tobacco use status. Also, individuals will transition between different tobacco use statuses according with predefined or predetermined transition behavior probabilities. In this slide, we can see a graphical representation of tobacco use transition for two model scenarios. On the left, we can see a one-product case scenario with three tobacco use statuses for never, current, and former use, with three associated transitions that relate to initiation, cessation, and relapse. On the right, we can see a two-product scenario with 9 possible use statuses in which the first and second terms correspond to the use of first and second products respectively. This scenario allows the model to monitor in total 27 transitions, potential transitions classified into 4 groups, represented in this graph by colors, associated with product initiation, cessation, switching, and relapse. In the next few slides, I will present an example considering this two-product scenario and considering data from cigarettes as well as for non-combusted tobacco products. The dynamic population model approach can be used to project the impact of a hypothetical scenario on tobacco use behaviors, morbidity, and mortality. Examples of hypothetical scenarios include the introduction of a new tobacco product and also the implementation of a new policy. In this presentation, as an example, I will focus on the potential implementation of a nicotine product standard. Then the model will update the initial population over a pre-specified simulation period and estimate model outputs for a baseline scenario, which assumes that there are not further changes due to regulatory actions. Also, it will produce model outputs for the hypothetical scenarios, taking into consideration potential changes in tobacco use behaviors and mortality. This will be as a result of the implementation of a regulatory action, in this case, the nicotine product scenario. I would like to point out that the DPN is a deterministic model. Therefore, the model does not incorporate uncertainty directly into the mathematical formulation. To account for uncertainty, we use Monte Carlo simulation to compute lower and upper bound limits for each model outputs. If you are interested in looking at the formulation for this Monte Carlo simulation, you can find details of that strategy in the 2018 New England Journal of Medicine publication. In regards to construction of model input parameters, I would like to emphasize here that this is a critical piece of the analysis, and it involves getting data for both the baseline and hypothetical regulatory scenarios. For the baseline scenario, for example, and considering a baseline year to start the simulations, US population data stratified by sex and age, as well as birth and net international migration data, was obtained from US Census national population projections. Mortality rates and mortality relative risk for never, current, and former users of tobacco products can be derived from data from the NHIS and the National Health Interview Survey linked with National Death Index mortality data. Also, to populate tobacco use prevalence into the model, considering the 9 tobacco use statuses for a 2-product scenario, we can use data from different national surveys, such as NHIS, the National Youth Tobacco Survey, and also PATH data. The smoking transition behaviors were obtained from age period cohort model outputs, considering data from NHIS. Also, results from a PATH data analysis were considered. Finally, for a hypothetical regulatory scenario, Data regarding potential changes in transition behaviors as a result of the implementation of regulatory scenario could be obtained from expert elicitation or assumptions based on findings from peer-reviewed publications. The DPN model produces yearly estimates for a variety of model outputs for both the baseline and hypothetical regulatory scenarios. Some of those outputs are population projections, tobacco use prevalence for both products, new initiators or quitters, as well as mortality and morbidity outputs. In terms of public health benefits, the difference between the baseline and hypothetical regulatory scenarios will give us an estimate of the potential benefits of the regulation through time. As an example, this slide presents some results that are shown in the 2018 New England Journal of Medicine publication for the application of the nicotine standard. Specifically, the model was used to compare a baseline scenario where cigarette smoking will continue to decline based on smoking in initiation and cessation trends, with a policy scenario in which the product standard is put in place in 2020 to lower levels of nicotine in cigarettes and other combustible products. The model estimates that about 1.4% of the US adult population would smoke cigarettes by the end of the century, in part because more than 33 million people will avoid becoming regular smokers. According to the model estimates and considering data from expert input, the potential product standard will result in more than 134 million years of life gained by the end of the century. Also by year 2100, more than 8 million tobacco-attributable deaths could be avoided. Please note that those model estimates are based on an analysis that consider an initial population as well as tobacco use prevalence from year 2015. Therefore, by updating input data to account for recent changes in prevalence and tobacco use behaviors, we can get different results. I would like to finalize this presentation pointing out some limitations and future directions for population model, in particular for the DPN model that I presented today. In terms of limitation, the DPN approach considers age and sex as population level variables, and a potential update could be considering disparity variables such as race, ethnicity, socioeconomic status, and geographical data. Also, the model is restricted to all-cause mortality. Therefore, incorporating cause-specific mortality and morbidity data is a potential update. Regarding future directions, as mentioned by Dr. King in his presentation early today, the incorporation of uncertainty metrics for both inputs and output model parameters could be explored. Also, it will be helpful to explore ways to incorporate assumptions regarding the impact of a policy that has never been implemented. Finally, as a research question, could biomarker data be used in mortality disease risk analysis? If possible, results from those analyses could be informative as input model parameters, and also to add new information to populate these models. Well, with this, I finalize my presentation. Thank you for your attention. I'm ready to take some questions. Thank you.